We know postnatal blood pressure peaks on days 3 to 6 postpartum when most women are at home, meaning there is significant maternal morbidity associated with the hypertensive disorders of pregnancy. There are multiple management strategies, and our review aimed to assess the efficacy and safety of these to better inform clinical practice, guidelines, and future research. The review was prospectively registered, and the search strategy was performed in collaboration with the Cochrane Group. We included all randomized controlled trials that used any intervention to reduce maternal blood pressure in the postpartum period. This included diuretics, antihypertensives, uterine curettage, and models of care. Our outcomes are summarized on this slide, namely looking at blood pressure control, any maternal adverse events, postnatal length of hospital stay and readmission, as well as longer-term cardiovascular outcomes. The data was screened and extracted by 2 independent authors with risk of bias assessed using the Cochrane tool. Certainty of evidence was evaluated using grade criteria, and random effects meta-analysis was used to combine data. A post-hoc network meta-analysis was performed for pharmacological interventions. Of the 944 studies identified, 40 trials were included in the review. 7 trials looking at diuretics were identified. These, when pooled, showed that blood pressure control was better with diuretics. However, significant heterogeneity was identified that was related to the trials that administered antihypertensives to both groups. The blood pressure control did not differ between the groups that used diuretics as a monotherapy. 9 trials were identified looking at antihypertensive versus another antihypertensive for non-severe hypertension. These showed that there was no difference in the need for additional antihypertensive when various different antihypertensives were compared to nifedipine. However, as expected, there was significant between-trial heterogeneity. The identified heterogeneity appeared to arise from ACE inhibitors versus nifedipine trials, in which the ACE inhibitors were inferior to nifedipine with regards to their blood pressure control. There was no difference in other outcomes evaluated. In terms of severe hypertension, 8 trials were identified. These showed that blood pressure control did not differ between IV labetalol and IV hydralazine when the results were pooled. There was no difference in the need for additional antihypertensives when nifedipine was compared to alternative antihypertensives, and there was no difference in other outcomes were reported. 4 trials looking at uterine curettage were identified. Mean arterial pressure was the reported outcome for blood pressure control, and when pooled, no difference between curettage and usual care was seen. In addition, no mortality or uterine perforation was reported. With models of care, 9 trials were identified, the majority looking at self-monitoring or management of blood pressure. The single study looking at neonatal sleep showed that blood pressure control was better when neonatal sleep was improved. With regards to self-monitoring of blood pressure, there was no short-term difference in the blood pressure control or postnatal readmission versus the usual care. However, blood pressure was found to be lower at 6 weeks postpartum. In conclusion, diuretics may aid in the postpartum management, however cannot be recommended as monotherapy. We found insufficient evidence to recommend one antihypertensive over another. However, some trials suggest that nifedipine may be more effective than ACE inhibitors or amlodipine. Uterine curettage is not effective. Lifestyle change and blood pressure self-measurement may appear to be promising in reducing the longer-term cardiovascular outcomes.